all the homework, and I'm sure it will be an interesting day of all the academics. Thank you. Namaste, Bhaskara Garu. My teacher.
I'm blessed to be in the city of Professor Krishna Rao sir. And so the Ishwar will be in responsibilities. In fact, yes, he was the one who brought me into the ambit of Efiages about 4 or 5 years before. Then now he has seen me along, and I'm proud to be with you today. I'm going to touch upon the basics. Maybe it is a little boring for the people who are already doing endoscopy, but still a lot of technology is also covered in this talk. So I'll be taking you through the hardware of the endoscopy. So my thanks to Professor Chandramohan, who was seeing me into the specialty of surgery, and what I am today is always hard work. And to all the teachers who made me to this stage. The Efiages concept is fairly new to the Efiages. Efiages is one of the oldest associations, starting back in 1991-92 conceived. But Efiages has been always, like now we felt the surgeon should be having a structured course on endoscopy, and that's where this concept and
formal fellowship course is also planned. This is the 4th course, and our Guru, Professor Krishna Guru, is the mentor. In fact, we call him the father of endoscopy of the entire country, because way back in 1981 or 82, he brought in the endoscope to the country. And I guess most of the senior endoscopists, including the medical gastroenterologists across the country, have got trained at some point of time in their career. And in fact, I am blessed to have worked in the same endoscopy suite which he created. That's where I learned the basics of endoscopy in Roypeta Hospital in Chennai. With that, we'll go into the topic. This is the few images from the last Efiages from Trichy. You can see the national president-elect, national president, national secretary, and Dr. Vipul. And one of the conveners of the Efiages board, Dr. Govindraj sir, is going to be joining us soon. The entire galaxy of the faculty were there. Just to start with, gastroscope was so not very comfortably looking. Erstwhile, it has to be very like a sword swallowing, it has to be there. Later, little bit of flexibility came, and now I'll take you through the journey of the endoscope. The endoscope has a very humble origin, starting with fiber optic direct viewing scope. Later it became electronic scope, then became video endoscope. Now they say capsule endoscope, and the technology is growing by the day. They can do even remote steering, and robotic endoscopes have come now. So to start with, these are the fundamental scopes: the upper GI scope, the side viewing gastroduodenoscope, colonoscope. And there are of course special scopes like choledocoscope, mother baby scope, or the spyglass, or of course the special multi-channel interventional scope or the jumbo scope, where you have 2-channel access, and now you have facilities to do endobariatric surgery, anti-reflux surgery, POEM. All those high-end work are also possible, where you have little bit of modification in this scope, which we will be talking about. So the crux of the day, the crux of the program is going to revolve around the video endoscope. So we are going to talk about and learn about fundamentally about the video endoscope and how it works. Are all scopes same but for the length? No. Upper J scope has its own length, lower J scope has its own length of 160 plus centimeter. It has different grading of stiffness, because the torque which needed for an endoscopy upper GI is much lesser than the torque and the push which someone has to use for doing a colonoscopy. And of course the therapeutic scopes, they have a different armamentarium of handling the accessories, because the maximum you do by an straight viewing scope is probably doing an endoscopy or an assistance with the endo intervention, whereas therapeutic scope and side viewing scopes have more channels. they have more devices which can pass through, and of course they need to handle the accessories in the comfortable way of the operator. And then the EUS and the node scope, I will not be not touching upon much, because this is definitely out of the domain of the program. So it is a much advanced, more technologically demanding scope. With that, I am going to talk about the components of the endoscope. I have one volunteer up here. I can come this side. So fundamentally, you can. So fundamentally, I am going to touch upon the principles of the endoscope. This is a Olympus model scope, where you have the most important thing is the control. This is where you, like your cockpit, where you drive the plane or where drive the car. This is where is the fundamental control. The most important thing from the patient's perspective is the insertion tubes, and of course the entire, I would say, the heart of the scope is at the tip. All other things are accessories. The brain of the scope is outside. So all these things are the patient side predominance. From this side onwards, it is for the optics, and this is where we do the processing, which we will touch upon as we go through the course. There are adequate channels. In fact, this alone can be a teaser. I think we will have the slides off. So starting from one end to other end, I will go through this end. This is the lens where the light is passed through. Now the current generation scopes are very advanced. You don't need to have multiple connectors, single connector for both light and processing, image processing together. So this is the light guide. You have the air channel. This is the connection to the video processor. This is the light source connector as a whole. There is a suction connector. This is the air supply connector, and of course the water supply connector. This is a sort of a universal cord, or the umbilical cord. That's what we call umbilical cord of the scope. And fundamentally, there are some 2-3 important scope makers which have been there for almost now 40-50 years, where the fundamental hand control is more or less the same, except for your comfort of little bit of handling. The most important thing is the up down angulation knob, right left angulation knob. Can you show? You know to handle. So leave this and show. So he is now showing the up down. You can see the tip when he is handling. This is the up down knob, and can you do the right and left? So this is the right and left, and then both the up down knobs and the right and left knobs has a lock, especially if you are doing an intervention, if you are doing a biopsy in a very difficult area like a gastroesophageal junction where we have to do a J maneuver, or when we are going to do a biopsy in the incisor of the angularis, or if you are going to do biopsy in the D1 D2 junction. There are some areas where biopsies are pretty much very difficult to do, because the scope keeps on moving according to the respiration, patient's comfort levels, all those things matter. And when you are alone, or when there is only one person to support you, these lock mechanisms help. These things can be learned as you grow senior towards handling the scope. And then once you come down, these are the two important valves. One is the suction valve, other is the air water valve. You should be taught, people who know will be knowing, sir will be teaching about how to handle these are the two important valves, without which it is as good as not having the scope. These are the two important stuff which is throughout your career, it's the most important buttons you are going to handle. Later comes the control section. This is the biopsy valve, or you can use the brush or the sclerotherapy or the band. Everything goes through this channel, and then if in special scopes you can stiffen the scope, but most of the scopes do not come with the stiffener. Mostly for colon or more longer enteroscope, the stiffeners are useful. And later this is the connector or the boot, and insertion tube, bending section, and of course the distal tip. Thank you. With that we will go into more technicals. This is the internals. If you see, you can see the entire 3 colored lines almost runs through the entire scope. Of course these valves control the movement of air, water, and then the degree of suction. And of course, the biopsy valve is a sort of a valve which there is an adapter over it, so it does not affect the degree of air and suction passing together. And of course, where at the end you have a separate air pump and then you have a separate water bottle which runs together, and apart from that you have a separate suction connector which is independent of the processor. You need to have a separate suction unit, and all the other optical gadgets are always there associated. Now we will go to the heart of the endoscope. Carefully watch, because all the procedures, all the things are fundamentally driven by the hardware knowledge what you have. Here what you do is, this is the cross section, this is the end on view. You can see there are so many stuffs, even though we see a small 9 millimeter or 11 millimeter scope, so many things go inside through the tube. The amount of technology which goes in and the durability of the technology goes in only should remind you, always handle the scope with utmost care. That is the most important message I would like to give, because so much of technology goes into the tube under the covered black sheet. So this is the light guide protection tube where optical fibers are there. Next is the water jet tube, and next is the most important thing, the eye of the scope, or the CCD, the charge coupled device, and that is where the image gets processed and then it is converted into electronic signals. And of course, air water tube, depending on the type of the scope, you may have 2 channels for the working instruments to pass. If it is a diagnostic scope, you may have only 1 channel. As well, the newer generation scopes which are upcoming have a direct LED tip light source. Whatever these scopes currently what we are having, all have a light source in the processor, from which there is some form of transmission through the optical fiber bundles have to happen. So optical fiber bundles, depending upon the type of the procedure, depending upon the type of the scope, you may have 2 light bundles or 1 light bundle. As well, you may have other special channels depending on what scope you are using. The predominantly the largest is the biopsy channel. Usually it is 2.8 millimeter. Very rarely you may have even 3.2 millimeter channels, and there are some special devices like Apollo and other things where they have tubes running along with the endoscope, because their devices are so very big, suturing devices, you can do endoclinch, all those things they run along with the tube and not inside the tube. Those are all very advanced scopes. So the insertion tube which we have spoken, the flexibility of the tube is the most important thing. It should not be so flexible that it buckles, and it should not be rigid the patient finds difficult to take it in. As well, that is why in colonoscopy I showed a knob to adjust the stiffness, and then the safety of the distal tip. It should not hurt the patient, at the same time it should be steerable, at the same time it should give the best possible image and comfort for the endoscopic operator. Of course, the bending section and the angulation, which I will touch upon now. What goes into this black tube? In fact, if you see, there are sort of at least 4 layers before the working channels come. One is a combination of polymer top coat. This is what we see outside. Later, depending upon the degree of the stiffness what we want, this is a polymer A and polymer B, soft resin and hard resin combination. This can be mixed in the right proportion. If it is an apogee endoscope, the choledocoscope is the most soft scope, or the spyglass is the most soft scope available. As we grow more on therapeutic side, it becomes stiffer. So how do they make it stiff? They have polymer A and polymer B combination, which makes the base layer. Then you have the outer covering called the stainless steel wire mesh, which gives integrity to the scope. And of course, the outer spiral metal band and inner spiral metal band depends how flexible your scope is going to be. And then, having spoken about the skeleton of the scope, now we are going to do the technical aspect. So to recap, polymer cover, outer spiral, inner spiral, then comes the entire stuff which goes through this channel. So you see the water jet channel, light guide fibers, this wire for adjustable stiffness, you have the biopsy and the suction channel which is shared together, and you have the charge coupled devices signal wires, and you have the air channel, and of course we have 4 angulation wires which is for up and down, right and left. All right. So with this background of the technicals, we go now into the movements. I think you demonstrated the movements, it's fine. So how it works is something very fascinating. So you can see this is the up angulation wire, this is the down angulation wire. You have pivot pins and rings. These are the pivot pins and these are the junctions. You have 2 levels, one is for up and down, one is for right and left, and you have the angulation wire fixed to the end of the tip of the endoscope. And you have something like all of us have driven at some point of our career motorcycles, something like a motorcycle chain. There is a chain and sprocket device which works one for the up down and one for the right and left, and eventually there are 4 cables which are like our nerves of the body, where eventually it makes to move at your own control. The bending section, they have to be extra careful, because bending section, up down movement and right left movement are not universal in all the scopes. Some scopes have more than 70, they do not allow more than 70 degrees, depending on the model of the scope and depending on the procedure which you intend to do, the amount of degree of angulation can be chosen. And the most important message here I would like to say is, when you are doing a biopsy or any instrument, ideally it is done when the tip of the scope is kept in straight angulation. If and if you need to do something, allow the biopsy forceps to come up, then you angulate, because if by chance if you accidentally force it, the inner channel, how much ever sophisticated is the outer channel, the inside channel of the accessory passage also is very sensitive, and the damage which is happening inside is very difficult to assess unless you have special gadgets. This is the stiffness quotient. This is for you to understand, it is little bit technical, but you should be aware the last 40 to 60 centimeter is the normal transition zone for the colonoscope, above which the scope is fairly firm, below which the scope is fairly supple, because this is how it has to negotiate through the curves of like sigmoids, splenics, hepatics and ileocecal junction. And the working schema, I have spoken about the scope. Now we go beyond. This is where the connectors are done. This is a light source. Usually, initially we all had halogen light source. Now we are using xenon light source. The minimum wattage of xenon in luminosity lux level is 300 watts, but there are more high end scopes and there are more scopes which are using, apart from xenon, now we have the LED light sources as well. And of course, the air pump and the water bottles are essential, and it is offered out of the processor. The illumination can be from a unified processor in a single, like one brand Pentax and the recent brands of Olympus, where they have light source and the video processing in the same unit, or there can be from a dedicated light source. The newer generation of course has a direct LED source, makes the scope much lighter and much portable. Then, having talked about it, we now go into the focus part of it. See, a normal focus is like this, but if you want to have a near focus mode, you can zoom in. There are 2 zooms which are available. One is an optical zoom, the other one is the digital zoom. The more the optical zoom, the better the image. All right. Now, to close with, how do you capture the image and how do you assess a quality image? This is the CCD principle, where it is the charge coupled device. It is like a photosensitive surface, multiple colors, principally the magenta, blue and green. What really happens is, when the color code hits on the CCD screen, it stimulates the electron, and the passage of electron evokes a electronic signal. So what really happens, there is a sort of a photodiode made of silicon oxide. There are multiple circuit lines. When the electron moves from this side or that side, and then as much as the intensity of the light, it also stimulates the electrons. So eventually what happens, this is, I have escalated or I have made into more complex stuff, where it can be made to pass through to one line, or it can be directly vertically CCD lines can be So depending upon, they can be amplified from a group of lines or from the entire lines. And then eventually the color image, what really happens is, it is an ultra electron level simulation which is eventually converted into pixels, and then from pixels it is processed through an image processor. I will show you how it is processed. This is how the image is processed. See, imagine this is a colonoscopic picture, this is a CCD, this is a bi-directional CCD, both vertical and horizontal. Your image is pixelated like this, then pixelated into more deeper, then subtypings. See, imagine at this point of time there is no signals which are eliminating. So this signal is converted into an electronic signal, and eventually the electronic signal is made into output signal, and eventually this is a dynamic process. You won't believe, in 1 second not less than 60 times the electronic data transfer happens. Less than that you start pixelating, you have frames, you see frames. The more higher the high definition, up till 120 frames per second scopes are at this point of time available. And then you would have always seen, when your camera or in your phone, if something goes out of focus, the image gets blurred. But in none of our career you would have ever noted that endoscopic image ever gets blurred. Have you noted why? It is so very well designed. What really happens is, this chart you carefully watch, this is a zone of the standard colonoscope. You can see anywhere from 1 millimeter to almost 15 centimeters, there is no distortion of the image. That is a very important lesson one should learn, because the scope gives such a wide angle, and that is the reason it becomes so expensive also. And as you grow into higher scopes, the zoom mode and the close focus high definition colonoscope or the endocytoscopes, the iris zone becomes narrower and narrower. It becomes very narrow. So diagnostic scopes give the widest possible image. As you escalate above to the therapeutic scopes, the iris level goes down. So you need more experience, and pan scanning will not be possible, where you will have to have definitive clear cut stations for you not to miss anything. The last one, how will you identify whether it is a normal definition, standard definition, high definition and your 4K? Now up till 16K and 32K scopes are under research. Presently 4K scopes are out. So this is how it is like any other TV. All of us have graduated from the regular cathode ray tube TV to now we have the high definition and 4K TV. Similar technology goes good, but the degree of interference measured in the type of noise, the image, it is not the sound, the noise is the interference to the image. The lesser the noise, more clearer the picture. The medical imaging has one more safety measure, that at no point of time there should be a discharge of static electricity because of so much of electronic stuff which is happening inside the patient. So it is a medical grade imaging standards. So after that, this is how you regularly reconstruct the image, and now people have wanted, this is benign or malignant, is this a lesion which I am taking the biopsy in the right part? That is where they started subtracting the colors. They subtracted the red or subtracted the green, they subtracted the blue, eventually they got like that. So they understood, if you subtract one color, you get a better or different information from the lesion. So what they did is, one should be very much aware, the endoscopic color image is dependent on the hemoglobin of the patient. Can you believe it? Because hemoglobin is the one which gives the color to the mucosal tissue. So what they did is, the hemoglobin peak is 450 nanometer, and then the second peak is 540 nanometer. What they did is, they very cleverly, the engineers, subtracted the 415 and the 540 nanometer, and they played with the colors. So whatever way you want, it comes in 3 different things: narrowband imaging, eye scan in pentax, and Fujinon FICE. It is a Fujinon interactive color imaging. And then later they realized, why can't we fuse the normal color chip image along with the narrowband imaging? That is what we get the best of the images now. where you call as the chromoendoscopy. So with that, this is the fusion of the entire image technology what I have spoken, which gives the fundamentally three colors that holds good for good, but how the three colors are processed are the advancement of the technology. And you can see that's where when I hope when Krishna Rao sir started, where the image was of this quality, now we get to see even the microscopic picture when we are doing the endoscope itself. To close down the last few slides, the processor, I already have told you, it can be a unified processor, it can be a separate processor like a light source and the image processing, and lot of processing happens here. One for giving you the image, and now the modern processors have reporting facility. You can make image captures, you can make video captures, all those things are coming integrated. And wherever you possible to afford, you always invest on a tower system where it gives all the components together, the printing, suctioning. Now you are using carbon dioxide for endoscopy. So all those things should be had in a tower system where your patient safety is ensured and your scrambling of gadgets will be minimal and you will be able to concentrate on patient care. One or two slides about the recent advances. Of course, this is not a recent advance. The variations. What really happens is, this is a side viewing scope where the view is 90 degrees to the right angle. What really happens is, all those things up till here are the same. There is a 110 degree prism which is kept for the CCD to work on, and the optical fiber cables are bent, and there is an illumination lens which is kept separately. The most important thing is the endo lift, where the biopsy or any accessory which comes straight can be kept in a normal angle, 45 degree angle or a 90 degree angle by using a endo lift or a elevator. And then the most exciting thing, that echo endoscope or endoscopic ultrasound, these are fundamentally, they have a transducer along with the whatever we have said so far. There are two types of transducers, one is a circular one, other is a horizontal one. The imaging is done in 360 degrees here, imaging is done for 180 degree, both as specific areas of application. You can do fine needle aspiration or fine needle true cut biopsy itself through these channels. And the real hero of the present moment, now the capsule endoscopy. With so much of gadgets which you are speaking, everything has been put into single stuff, hardly a capsule size, and then they can be immediately lively transmitted through a wireless image, and you can see in the computer. In fact, it takes about more than 15 images per second, and now the modern capsules have both sides. Image can be captured from front and from the back, because they felt the back area can be blind area. So it takes images on two sides, and the modern capsules are steerable capsules, because like endoscopy people wanted, I want to stop here, I want to see this place better, that is called steerable capsule. And the ultimate is the disposable endoscope, is already available for safety and security reason in highly infected patients. At this point of time, we have just had this technology, quite expensive, but the cost will come down. A day how we dispose our syringes, we may also dispose the endoscopes after every patient use. Thank you so much.
Thank you, sir, for your wonderful presentation. Any questions? Now we will move on to next presentation by Dr. Ishwar Murthy sir. Steps in diagnostic endoscopy.
Okay, I think we'll just try to make it more interactive. This is one of the important lecture for the beginners. When I say beginners, who are just about to handle scopes. People have already done probably what I would think is how we orient to the various areas in the upper GI tract. So I need to thank these two guys. Of course, Basil Iskovich introduced us to the field of flexible endoscopy, and Professor Krishna Rao brought the endoscopy to India and made all the surgeons to do. And we, in the middle, with the laparoscopic innovation, we lost our track, but we are now catching up to do. I think the surgeons we have to do. There's a lot of potentials and prospects if you learn endoscopy. So with that, let's move on to the steps of upper GI endoscopy with the two important aims for the discussion. One, I'm going to tell you how we recognize various landmarks starting from your incisors, teeth, when we pass the scope down into the D2, that is our end point when we do upper GI endoscopy, various spots, how we go there and how we are going to, reach that area. So this, if you are able to understand, this will help you when we are going to do the live procedure in this late morning. Okay? But there are, because you are going to be with the mentors, so we are going to use some words or terminologies which may be slightly different from the books you read, like books. So that's why we modified few points, and we made a textbook for itself. Actually, the book you have been all given as a compliment. You feel free. The next 1 week, I expect all of you to finish reading the book, because the best way, it's not hardly 100 pages. So it's a very important topic is also on this, because before we do any endoscopy, what we do is a pre-endoscopy ritual. When I say pre-endoscopy ritual, what I mean is, you have to make sure your equipment is working. Like a pilot about to start the plane, cockpit drill. So you don't just take the scope, just do, oh, the suction is not working, the light is not enough, or the water bottle is empty. All those questions should not arise. So there is a 6-point. All these points I will be telling with us. So this is what we call the equipment checklist. Without the equipment checklist, green signal, the staff who is going to assist you should not give the scope to you. So you need to train them. It is your ritual. Okay. The next important thing is patient checklist. What I mean by patient checklist is, don't say that I am the consultant, I will just got the scope. Before you talk to the patient, why the patient is on the table, indication. Should we do the endoscopy? Is there any contraindication? Very important, because even lately, last week, I had a patient with a severe, a 70-year-old man with a severe epigastric pain, sweating. The resident brought, sir, this patient is a severe gastritis. But I had some funny feeling, it's not right. Why don't you just do an ECG and then we'll do the endoscopy? That's what am I. So the last thing you want is to patient on the table collapsing, then on retrospect, you know, that is a case of MI. Endoscopy was a wrong investigation, and that precipitated the catastrophe. That is not be the case. So that should be a definite. You should exclude like a perforation, bowel ischemia, or respiratory cardiac problem before you put this endoscopy. So there are some definite contraindication one has to see. Of course, drug history is very important, especially because there are a lot of diabetic patients fasting for overnight. They will be already half sedated, and you are giving midazolam, that's it. They will not make up because of hypoglycemia. Very important drug history. Before taking a biopsy, is a patient on aspirin or warfarin. So drug history is important. Don't delegate to your, or you have a chart where everything is documented. Along with what the most important document to protect you in the court, of course, is the informed consent. There is no oral consent. It should be written consent, explaining. The written consent, ideally, in ideal words, should have a patient information leaflet in your own language, in your own places. You just plain what endoscopy means, what we are going to do, what you are going to expect, and what's the benefit and risk. All those things in the patient's own language, you write it, design one and attach it. I've read the whole information leaflet. After that, I'm happy to give the consent. If then and only, it will become a valid consent. Okay, not just 4 lines in English. So that's not. So this is the next important thing. Of course, other things are there. So once you have done that, learn from the endoscopists how they are reaching that area, because somehow we go and see places. That is not important. But what is important is understand our language. Our language is very simple. We treat the monitor like a clock. Like here, right in front of you, there is a monitor. If you imagine, when I say, oh, can you see a lesion at 6 o'clock, 12 o'clock, 3 o'clock? Exactly what we mean. For example, that is 3 o'clock, the right wall, or 9 o'clock position, like that we'll be saying. And in Olympus scope in particular, because we will be using more of them today, and if you see the insertion channel, when we insert any accessories, it always comes out here, as you can see here, at 7 o'clock position. See 6, so around 7 o'clock position it will come out. So, when you have any lesion in this part, it is easy to take a biopsy. In other words, always bring the lesion to the bottom half of your screen, intervention is easy. And if the polyp is hanging like a hanging gardens, it is very difficult to pluck the fruits from the roof. Okay, for example, there is a pedunculated polyp dangling at 12 o'clock position, you can rotate the scope in such a way, you try to bring in the lesion to the bottom. Always work on the floor, never work on the roof. That is a very fundamental in endoscopy. Next important thing is, there are only in the control head, Kanagavel nicely said, there are only 4 important things: 2 wheels, 2 buttons. The 2 wheels, of course, we say it's a big wheel and small wheel. The most important wheel, of course, is the big wheel. Okay, the big wheel is the main important thing, and how you turn it. Okay, can you take the scope for me? So, the big wheel, it always says it is for the up and down movement. That is the most important wheel. We say you try to turn it towards you or away from you. That is the easier language for you. Okay, let me just. So, I'll just hold it here like this. Okay. See, for example, this is the big wheel. All of you can see. If I turn it towards me or away from me. So, when I say towards me, what it happens is it is going upwards, and when I completely turn and there is no further turning is possible, it becomes a J maneuver, of course, like a hockey stick. So, the big wheel does most of the function. For upper G endoscopy diagnostic, most of the time what we will be doing is various degrees of turning the big wheel towards you. A little bit when we enter the oral cavity, and then straighten again when we enter the esophagus, of course. When we go into the stomach, slowly we will be going body, antrum and into the pylorus like that. So, in other words, slowly we will be increasing the curvature, and whether we will use a small wheel we seldom use. Small wheel is important when you do a ERCP, because it is useful only to turn to the right, that is going into the second part of duodenum, and instead of the small wheel, because for the beginner I find it is difficult to reach both the wheels, especially with the one hand. You need it momentarily, but don't. This hand has to be dedicated to the insertion tube. You hold it somewhere here. I would say probably when you start around 15 to 20 centimeter away from the patient mouth, your hand. If you hold it here, it will be dangling. You will not have a control. If you have it here, you will have no freedom of movement. So, it will be ideal optimum is around 50 to 20, and always like a turning a key, clockwise and anti-clockwise turning of the shaft of the tube makes all the difference. For example, you do like a clockwise or anti-clockwise. So, when you turn clockwise, then you turn the scope right side. Okay. Then if you want to turn right side, for example, I want to turn this side, I just turn clockwise like this. Anti-clockwise, go to the left side. So, this actually takes the movement of the small wheel. In other words, the small wheel job is done by a shaft. So, my big wheel, next is turning the shaft, second movement, and the third important thing is my body itself will move. For example, if I turn here, the monitor is there, then I turn myself little bit towards this side, to my right side, and then the scope also will turn to some extent to the right side. That is why most of you will see when we do the ERCP, they will be turning their body from away from the patient towards the trolley, the monitor, that is to the right side, because that way you keep the scope in the D2. For example, if this is the monitor, I told you 3 o'clock, 9 o'clock, the 3 o'clock is my right side. Okay, this is the right side, this is left side. If I want to see that side, for example, I will be turning like this. If I want to see here, I will be turning like that. In other words, my movement also will affect what part of the body or endoscope, the image you are going to get. So, body movement, shaft movement and the big wheel movement, 3 important movement which is going to determine how we are going to steer the scope. And of course, the next important thing is these 2 buttons, as you can see, the superior button and inferior button. And both are detachable, as you can see, the superior button, and nicely it is color coded red, always the roof button, you say it is the roof button is red, R for R, you remember, and R superior button, S for S, it is suction. So, whichever way it is a suction button, very easy. And the inferior button, okay, or this is blue, the bottom button is blue. Okay, because why it is color coded, you do not want to take this and try to put insert here, try to damage the button. So, it always goes, the blue one is the bottom one and the red one is top one, and the ring is color coded. So, it is all easily made, so everybody can easily understand. The inferior button is actually having a dual function. In other words, one button, two jobs. What are the two jobs? That is, when you just put your index finger on it, or the middle finger for that matter, and just close a little hole there, and it insufflate. In other words, air from the pump will come all the way through the umbilical cord, and it will come, it will come and insufflate. Insufflation is for the success. So insufflation is by, okay. When you press the button, instead of putting the hand, just press it hard, then it will instill water. So that way you clean the lens. It's like wind mirror you cleaning as you drive in a rainy day. So in other words, insufflation continuously you can do, installation intermittently you do. So the both the functions. So this is very important button for you. And how you are going to hold the control head makes all the difference, because nowadays we have a lightweight endoscopy, okay, hardly a couple of kilos or less than that, so you can hold it better. So in the first web space you hold it like this, embrace the scope with the two fingers, and these two fingers you dedicate for the buttons. Okay, this is the index finger for the superior and the middle finger for the inferior button, like that, and the thumb of course is for the wheel. Okay. So this is the way you, so don't try to, so this is always should be glued. Usually you have to keep it all the time, and whenever suction is necessary, press it, or otherwise it is always insufflating. Insufflation continuous. Okay. And if the patient is burping, patient feels uncomfortable, then of course you can take off. Most of the time you keep insufflating. That is the only way to see a clear view. So this is all about the buttons, the functions. You have to be clearly understand as a beginner. There should not be any confusion. I told you about the insertion tube, clockwise and anti-clockwise twist, and how we are navigating, and this is the way we stand. You see even today, because what we speak, we preach, and also we follow the same principle. It is not like that. For doing an endoscopy, however small your unit, try to have minimum 4 people, I would say. Why? Because each one has a dedication. For example, of course, I will be standing right in front of the patient with the patient in the left lateral position. This is the most important. Girl, she will be holding the mouth guard. Okay. In other words, for example, she will be holding like this, in the patient in the neutral position. This is not good, this is not good, this twisting, it will be exactly neutral. But a small pillow will do all the jobs. And victory sign, she will keep like a victory sign in the left hand and hold the mouth guard, and the other hand, as you can see, it's in the occiput. So the head should not be extended like this. With the patient, the scope goes in, the patient should welcome the scope like a Japanese position. So what you call. So he will be having a little flux. So flexed head will always is easy to insert. If the patient goes like this, it will be difficult. That's why this occipital pressure, so that I will avoid patient extending the head like that. So she is doing that, and she will be talking to the patient and say calming and reassuring the patient. So she knows what's her duty. Of course, there should be a suction available. If at all any oral fluids, she will be sucking also. And of course, the next patient, the staff nurse is this one, what we call a restraining staff, because the patient, as soon as you put the scope, the patient will like to pull off the scope. So she will hold the hand if necessary, and she will look at the monitor, she will give any drugs and everything. So she is a injecting nurse and restraining nurse. And the third nurse is the most important nurse to me on my right side. She will give all the accessories. I need the biopsy forceps, I need this and that. She will just get everything. She is a nurse with anticipation. When I say nurse with she knows beforehand what I would require. So this should be the most experienced person, of course. And the fourth one, if you have a luxury, she can do all the documentation and imaging as you go. But nowadays, with the press of a foot pedal, we can do that. She can dispense with this staff. If you are hard of staff, at least 3 people I would say is essential. Okay. Now coming to the actual steps of upper GI endoscopy. As soon as you pass the scope, the first important thing is orient yourself in the oral cavity. 3 structures you have to identify. What you should not see is the teeth. When you start seeing teeth, that means patient is pushing the scope to the sides. Okay. So one least thing is always, it's like a tracheostomy when you do, always keep yourself in the midline. So if you go in the midline, all you see is, the first important thing is the tongue will be seen at in the roof, 12 o'clock position. But that is the most important bizarre appearance you may look, because you know the tongue is on the floor like that. How it comes in the monitor, look on the top, because of the scope is curved like this. So it is upside down image. The first image itself, what you see the oral cavity is actually upside down image, because when you ask the patient to open the mouth to place the scope, you expect the tongue should be in the 6 o'clock position, like somewhere here, but it is on this, and that is better to be in that position, because then only you will be able to insert. Okay. Always try to keep the scope in such a way the tongue is here, the soft palate and uvula is here at 6 o'clock position. Then you go, yes? You are not able to see? Yeah. This one is the tongue and this is the uvula. Okay? Next is, as you enter further, you will be able to see a glimpse of epiglottis. The epiglottis is the one easily when you do endotracheal intubation also you will be seeing. Okay? This is actually a bit of a tongue and this is a vallicula. Okay? Behind the posterior one third of the tongue is a vallicula, this is epiglottis and we need to go there. These are the three important structures we need to identify. After that, we will go to the 15. There are numbers from the undergraduates times we all know 15, 25, 40. 15 at the entry of the esophagus, 40 at the exit of the esophagus and the ideal middle 25 that is the narrowest portion of the esophagus that we know. So, 15 is a number. Here is a thing when you see this is anesthetist territory and this is the endoscopist area. So, you will be seeing of course, when you go to the 15 the vocal cords, okay, here and right and left vocal cords, arytenoid fold and pyriform fossa and postcricoid region. This is the area. Okay. In other words, you need to clearly visualize the vocal cords, try to go in here. Actually, as I have seen all the marks here, this is 3 o'clock position, this is like a monitor, you treat it like a monitor. This is 3 o'clock, 6 o'clock, sorry 9 o'clock, 6 and 12. So, 3 o'clock is your right vocal cord, because next time when you see a lesion in the vocal cord, you should not get confused, is it right or left. So, that is the right vocal cord, always remember that side is a right vocal cord, this side is a left vocal cord. Okay, it is very easy. So, because you stand right side, left side like this you imagine, and arytenoid fold, pyriform fossa lesion, and usually we go into the esophagus either in the middle or through the left pyriform fossa. Okay, I will tell you in the live what happens. Then the thing you should not do is, if the patient is coughing or restless, if you push the scope, sometimes once in a time it will enter the bronchus. How do we know the bronchus? Means patient will become blue. That is not, the patient will be distressed, coughing, and the main important thing is you will the typical characteristic tracheal rings, one tube becoming 2, even 3 multiple tubes. That means it is bronchus. As soon as you know, you take it out. That is the best important thing. Okay, you have done it. So, the most important thing is you recognize that you are in the wrong place. Okay. And the other thing, we have done a bronchoscopy sometime when you go through the tumor, esophageal tumor, sometimes people do perforation without knowing they have done it, they will go. That is a very sad situation, but the most common thing is at 15 centimeter, if you are not waiting for your time, you will enter into the wrong tube. But once you enter the esophagus, it is like a cakewalk, because esophagus is like a motorway. From 15 to 40, it is like a straight limb, because it is very simple. The two characteristics of esophagus, one, it is empty. Second, it has a peristalsis, powerful peristalsis. When I say empty, why it is a important word? Because when you see esophagus, there should not be even a drop of fluid or a food inside. When there is a fluid in the esophagus, food in the esophagus, there are only two things. It is achalasia cardia, or there is some distal tumor like a esophageal cancer, like a lower esophageal cancer with a low. Otherwise, there is nothing. Patient, even if they had some vada, even half an hour before he had food, the food may be in the stomach, but nothing should be in the esophagus. So, any food in the fluid in the esophagus is the pathology. It ought to be explained, because achalasia is underdiagnosed. That is why I am telling you repeatedly. Okay. So, 15, 25, 40 is the golden number. So, why it is a 25 is important? Because there are 3 interesting things you may be observing in a very thin individual. What are the things? Aortic arch crossing, or left main bronchus, sometimes a pulsating left atrium. They are all more or less in the anterior, somewhere here you will be seeing anterior, because posteriorly in a thin patient you will be seeing the spinal column. Why this is important, anterior wall, posterior wall? Because when we do later, when you are giving more advanced, I want to do poem, they will ask you whether you are going to do anterior myotomy or a posterior myotomy. When you say posterior myotomy, that is at 6 o'clock, just in front of the spinal column they will be doing. Anterior myotomy somewhere here in front of the mediastinum they will be doing. So, you need to know exactly your trajectory, your orientation should be there. So, the left atrium, the pulsating heart will be seen anteriorly at 12 o'clock position. Okay. And of course, you will be reaching the stomach more or less in adult around 40 centimeter. That is what we call the Z line. The scomo-columnar junction is Z line, what we call. It need not be drawn like a pencil. It will be star shaped, flame shaped. It will be of various funny shaped, okay, like this, a typical Z line and a atypical Z line, and the Z line is brought nicely to you if you are using some special imaging, as Kanagavel said, narrowband imaging. If you just press that button at the time, the difference, because you know esophagus is pale mucosa, stomach is a pink mucosa. The transition may not be apparent for some beginners, especially when you use the basic scopes, like for example, some scopes are very basic, available 6 lakhs, 7 lakhs, they may not be able to see that resolution very well. Whereas we have more advanced scope, or we have a contrast imaging, image enhancement technology available, like SPICE technology or eye scan or narrowband imaging, you will be able to see that, because the Z line is a very important thing for two reasons. One, of course, you will be able to see any small changes in the inflammation, like all the grade 1, grade 2, grade 3 esophagitis of GRD happening just above this Z line. And second, Barrett's esophagus is one entity one has to recognize and target the biopsy. For that reason, you need to know that. Okay? And we enter the stomach. And how do we enter the stomach? Two things will welcome you. One, presence of rugal folds. Of course, you know you are in the right place. A little bit of fluid, puddle of fluid. Because as soon as you can see the stomach, you enter the body of the stomach. That is a very important statement. In other words, in the stomach, we don't enter the fundus. The fundus is seen only on our way back. When we go in, the first stoppage is body, then the antrum, then the pylorus, D1 and D2. That's the way we go. We never worry about the fundus, because once you go into the fundus or trying to look on your way in, you will get lost. Because the problem in stomach is people get lost. They spend a lot of time trying to reach the pylorus. That's where I find a lot of beginners they feel. So how to reach the pylorus as quickly, as efficiently as possible? I'll tell you the trick. First of all, you orient yourself. Once you enter, you orient. This is the most important thing. See, for example, when you enter here, this is the greater curvature, this is the lesser curvature. Okay, you are going to go upwards like this. You go upwards. So big wheel, when you go upwards, that's a big wheel is the most important thing. Okay, this is the most important thing. For example, this picture, okay, 3 o'clock is posterior wall, 9 o'clock is the anterior wall of the stomach, 6 o'clock is your greater curvature, 12 o'clock is the lesser curvature. Okay, 6 o'clock, you remember 6 now, 6 is this, 6 o'clock. So this scope has to be taken along the greater curvature. This is what we call a long route. Why? Because this is the one sure way of entering the pylorus. If you take this, that is through the roof, through this 12 o'clock, you will be actually hidden by, or you will be disturbed by the presence of the incisura, and you will get lost very easily. So always we say you follow the floor. In other words, if it is like a swimming pool, you just follow the floor of the swimming pool. That is, in other words, you have to see this 6 o'clock. You always go along the greater curvature, long route. In the whole scope, patient may be swallowing, doesn't matter, you will eventually get there. But how to get there? So this is another picture to say posterior wall, anterior wall, greater curve, lesser curve, orient. Enter along the long route. That is the dictum number 1. Number 2, how to enter and reach the pylorus. You do 3 important maneuvers 3 times, you will enter the pylorus. What are the 3 things? I am telling you, but we will be doing in action. 1, the big wheel, I will turning it towards me, little bit at a time. Then I will be twisting the shaft clockwise. Third, I will pushing the scope every 5 centimeter, 5 centimeter of 10 centimeter. So every time will be keep moving. So 3 things I will do. I will turn the wheel, I will turn the shaft, I will push the scope. If I do these 3 things in a right proportion, about 3 to 4 times, eventually what you will see is the pylorus will say hello to you, because pylorus will be bang on there. Otherwise, you will be just wandering around. Somehow you reach. But I usually say you have to reach the pylorus in the next 20 seconds. That means you are on the right. So how to reach effectively, sure way of reaching is you do these 3 steps. Big wheel, shaft twist, push the scope. Okay, same proportion. And proceed the pylorus. And when you see the pylorus at that distance, you go close, try to bring the pylorus right at the center of the monitor. See, right at the center of the monitor. It is not here, not here. When it is at the center, it is easy to enter. It is the duodenum. Very important. If the pylorus is not looking like this, if it is up, down, or it is facing this way, side facing, very difficult to negotiate. Side facing, down facing, pylorus don't. You try to make it end facing, facing at you right in front of you, and then enter. Because most of the time pylorus will be wide open. Very rarely because of the spasm or pyloric stenosis sometime. Because this is the next hurdle people feel. They keep on moving, trying not to enter. Patiently you wait, bring it to the center, insufflate, it will open. Because it is always open. Because they try to receive food from the, so then you enter very easily. You should be an invited party, not forceful entry. There is no need for any forceful entry into the pylorus. And see, you are a little far, you are very close to the pylorus. Even you can peek into the duodenal bulb. Even before entering the duodenum, you can have a view of the duodenum. That is a beauty, because sometimes some interventions in the D1 we do it while standing in the pylorus. In other words, I am standing outside the door, still I will be doing something inside the duodenum. That I can do, because if there is a bleeding lesion in the anterior wall in the duodenum, I will stand outside this side, then I can insert the needle and give injection. So you should know all the knack of doing. Okay. So here again, this is the anterior wall of the duodenum, that is at 9 o'clock position. This is the posterior wall of duodenum at a 3 o'clock position. Okay. So this is the pylorus. Only enter if it is here. If it is here or if it is like that, you try to bring it. This is not ideal location for a pylorus. Then you enter. How to differentiate D1, that is duodenal bulb, and D2? You know, very easy. The duodenum, it is featureless. Here all the valvulae conniventis, you will be able to see the horizontal mucosal folds nicely seen. Very easy to differentiate. So as soon as you enter the duodenum, we say D1 and D2, but actually there are 5 important steps in endoscopy. I first go for the D1 bulbar part, post bulbar part, then I go to a place called superior duodenal angle, then D2, then try to identify the ampulla vata. So these are the 5 landmarks one has to identify on their way in, ideally speaking. So D1 bulbar part is this. Beyond this area, before you enter, I will show you in another picture. First, bulbar part. In this bulbar part, this is the posterior wall, anterior wall, 3 o'clock, 9 o'clock. Ulcers are more common here, they perforate. Ulcers are less common here, they bleed. That we know from our undergraduate time. But very important thing is, posterior wall of the duodenum is not easy to see, because very easily can be missed. I will tell you when we do the live how to handle. Okay. And here we will see the importance. So I have gone into the pylorus here. Okay. Bulbar, post bulbar part. See this part. Imagine this curvature. This curvature. This is what we call a superior duodenal angle. So there only you need to take a quite a acute right turn to dive into the D2. We say it is not turning into D2. We have to literally dive into, because the D2 is descending part, isn't it? So we dive into the D2. How we are diving into the D2 is you have to reach right up to the superior duodenal angle. In other words, the movements I am going to do in the wheel, all will be done while I am at the superior duodenal angle. You remember this now, I will tell you. Not while you are in the D1 or somewhere. If you do it in the all the turns in the wrong place, you will be still, you will be in the duodenum itself, D1 itself. So you have to go and identify this part, then you do 3 important movements again to reach the from D1 to D. What are the 3 important movements? Again same thing, you will be surprised to see. One is a big wheel towards you, small wheel away from you, or turn the shaft to the right, then turn your body to the right. Most important thing is the body movement is going to help you to enter the D2. The importance of body movement you realize of entering the D2. I will tell you actually. Then once you enter the D2, the final destiny is of course is the ampulla vata, which is sometimes difficult to see in our end viewing scope, because end viewing scope is not having a lens on the side like ideally a side viewing scope, duodenal scope, but still you will be able to see it around 9 o'clock position, the ampulla. Usually it is a only vertical mucosal fold in the midst of the horizontal folds. So that is a one way of identifying this, and on the top of it you will be able to see a nipple leg, and if you see the narrowband imaging, it will be very easily seen at 9 o'clock. So that is a fine, but if you are lucky or if you are happy or more experienced, even if we can, with the same scope, we can go into the D3, D4 also. But our aim is to teach you perfectly. Everybody is able to see right up to the ampulla water and able to identify lesion, because very often as a surgeon you will be having some patients coming with a stent placed in the duodenum, and we need to remove it after ERCP. For that, you do not send it to the person who has done it. Okay. So, this is a schematic representation of the same thing. I told you, you first turn the big wheel towards you, then turn the shaft clockwise, then I turn myself looking at the monitor. Previously, I was looking at the patient, now I will be start looking at the monitor. So, that is a one, that is around 90-degree turn I will do. So, that way I will try to, in other words, the scope will be retained in the D2 only if you turn away from the patient towards the monitor. As soon as you turn your body, the scope will be slipped back into the stomach. Okay, the very important thing, how to retain the scope always in the duodenum is never face the patient. Turn your body away from the patient. Sometimes you see endoscopists will be even showing their back to the patient. So, in that way the twist movement will retain the scope. So, you need to have a knack, because sometimes we keep on doing multiple biopsies, we will be doing maneuvers in the duodenum a long time. How to keep that in the same place is turn your body. So, the body movement is quite important. Okay. And the next important is the paradoxical movement. That word is another important thing. Colonoscopy is much more important. That is, as so far you will be keep on pushing the scope. Now, at the ampulla, what we do is we start pulling the scope, trying to shorten it. All the excess length gone inside along the long route, we are pulling, and the scope will not, the tip will not come out, because as I said, I turn my body. So, the scope D2, it is actually, it is nicely kept inside, so it will not come. So, it is nicely fixed in the D2. So, as I pull and pull, what was along the greater curvature now will be along the lesser curvature. Okay. I will show you. See, this is what will happen. So, initially we gone along the greater curvature, now it will be along the lesser curvature. So, in other words, the shortest length of scope will be used from the ampulla, and that distance is 60 centimeter. So, there are some numbers to remember for endoscopist. So, when I ask you 15, that is the cricopharynx, 40, that is the Z line, 60, that is at the ampulla through the shortest route. Okay. So, these are the three numbers you know. Then there is one more number, that is 50. I will come to that in a minute. So, when you come back, because still we haven't, the job is not over yet. We have only seen, 90% of the work is done. As you withdraw your scope into the stomach, there are three more important areas you have to see. Area number 1 is the incisura, number 2 is a fundus, third is a cardia. We haven't seen, because these all the three lesion areas are potential to have pathology. How will you see the incisura is the next important thing. Incisura is the big wheel, you see, while staying in the antrum, turn the big wheel little bit towards you. So, little to like this, then you will see a ridge appearing in the monitor like this. Okay. And it will be dividing the stomach into bottom, that is the antrum, and the top, that is the body. Okay. The ridge will be going roughly around 8 o'clock to 2 o'clock like this. So, this is the incisura, the commonest site or one of the common site of benign lesions, ulcers. So, never, okay, it is only seen on your way back. On your way in, you are not seeing on your back. And next is you fully see, this is incisura, imagine, this is antrum, the superior. So, in other words, the stomach is immediately divided into two portions, one above, one below, and complete turning the big wheel like a J maneuver, then you will be able to see a panoramic view of the fundus. And when you see the panoramic view of fundus, what we do is we keep pulling the scope like this. So, this is what we do. The last important thing we do here is what we call the J maneuver. All of you know, all people already doing, they know J maneuver. So, big wheel completely towards. So, what we do, we keep pulling, but never pull beyond 50 centimeter. Why 50 centimeter is important? Because we know 40 centimeter is a OG junction, and the 10 centimeter is taken by your bent scope here. Okay. So, for example, I am 50, and if you pull further, the hooked endoscopy will avulse the esophagus. That is as simple as that. If I keep pulling little bit more, what will happen is this pulled portion, it will come through the esophagus. You will imagine what will happen to the esophagus will be easily damaged if you pull beyond number 50. So, never pull the scope beyond 50 centimeter level. So, in other words, you have to keep watching the numbers here, or you keep educating your staff nurse, keep uttering the word that you will be looking at the monitor, you will be saying like counting 20, 30, 40. What does it mean is she is indirectly telling what level the scope is now. So, if she says 50, that time I have to straighten the scope, then withdraw the scope, very important. So, J maneuver, you stop. Now, what I am doing is I am deep inside the stomach and I am pull, so that I am getting closer and closer to the fundus. At one level I stop pulling, that is at level of 50, then straighten the scope, then take the scope out. That is a most important final step before exiting the stomach. Okay. See like this. So, this is the representation. So, I will be looking first initially big wheel up towards me. So, you will be able to see the incisura, then further up I am able to see the fundus, further up I am able to see the cardia. In other words, retreat and retroflex, that is called the terminologies we use. We retreat from the stomach, and as we do, we retroflex, that is J maneuver we do. Okay. And this is what I demonstrated to you. Okay. And this is what the cardia. Most important part is the scope will be actually hugged by this right crest of the diaphragm. This is the cardia, because one of the commonest things you want to know is esophageal cancer will be extending onto the cardia, or esophageal varices will be extending over the cardia into the fundus. So, this portion is very, very important. And in some patients with achalasia, you have to actually see the cardia whether the patient has any tumor. There is a condition called, all of you might know, pseudo-achalasia. So, they may actually have a small tumor right in this place, it will mimic like achalasia cardia. So, in other words, this place has to be carefully examined. The 360 degree of cardia has to be examined by an endoscopist, and any tumor in the stomach in relation to this area, how far it is you have to see. And a patient with a hiatus hernia, this will be lax. Normally, the scope will be nicely gripped by the cardia like this. If there is a gap between the scope and the cardia like this, it is hiatus hernia. Especially when you have more than, you imagine there is another scope you can insert, then it is a lax LES. Sometimes the hole is so big, you can put 3 or 4 endoscopy. In other words, more than, because scope is 9.2 millimeter. By the way, you should know all the diameter of the scope, because when you see a stricture, you should know if the scope is not passing through, that means stricture is so wide. So, because the scope itself is very thin, 9.2. So, you should know the diameter of everything. So, this is what we just, the last thing what we do is what we call the distensibility test. There is one condition some beginners will overlook, that is a linitis plastica, because it is a submucosal disease, and linitis plastica, the very important thing is it is like a leather bottle. The distensibility of the stomach will be lost. So, when you put air, the stomach will not distend. Okay, normally when you put air, all the rugal folds will disappear. When you start sucking, stomach will contract, all the rugal folds will reappear, matter of time. That is a beauty of all our endoscope, the stomach. If that character is absent, then you think this patient's stomach is not distending, looks very contracted. Suspect, you just put Cori linitis plastica. Please do CT scan, because CT scan will able to tell you exactly the thickening of the stomach wall. Then you can take a multiple biopsy, because sometimes targeting a biopsy itself for a beginner, it may be a challenge, especially in a case of linitis plastica. Some cases it may be straightforward. Okay. So, but when we are so much glued to the whole procedure, you should also know when to come out. Especially patient may not, you may be enjoying your journey as a beginner, taking 1 hour to do an endoscopy, but for every second for the patient is like 1 hour for the patient, because patient is conscious, uncomfortable. So, you have to be as sleek as possible. Okay. So, for that, keep on reassuring the patient. We will give a Xalocan spray. Sometimes we give midazolam also. That is what we call a conscious sedation. How much of midazolam one has to give depends upon the patient character. We say usually the Indian patients probably 1 to 2 milligram will do, if you especially an outpatient patient. An alcoholic patient we have given up to 5 milligram also. But always it is a good habit to have the antidote available. In an ideal setup, an antidote is available. If the patient is not going into respiratory distress or not waking up, and you want the patient to walk back, you have to give flumazenil. Flumazenil is an antidote available, and even though it is a bit expensive, 1 vial at least should be available in these are all like if you are giving some patients morphine or something, you have to have naloxone, something like that. So, all these drugs are essential life-saving drugs, should be available. So, when the patient is uncooperative, restless, or patient saturation is going down, never hesitate to withdraw the scope. Always there is some other day you can do endoscopy. After all, it is diagnostic endoscopy. Mortality is not expected, and you can't explain whatever you say. So it should not be like a life and death problem. Okay, and especially when there are major complications, if you suspect you have gone into perforation pulse passage, you withdraw the scope, involve seniors, investigate, admit the patient, all these things. That's why always in the bottom line of informed consent, the perforation bleeding risk has to be mentioned. That is one of the recommendations coming. Always in a subtle way. Even though it is very rare, rarely you may encounter some rare complications, and in that sequence you may have to be admitted and further treatment may be required. Like that, one word has to be in the informed consent. So these are all the legal requirements. Okay, and of course after the endoscopy, endoscopy has to be cleaned and disinfected. Okay, always 20 to 30 minutes before the ideal world. Patient has to be given all the information what we have found. If not, the patient already sedated, the relatives, and we need to give them a written report, a nicely written report. And 30 minutes they should not eat or drink because of xylocaine spray. 1 day they should not drive. These are all internationally accepted thing, because midazolam, even though short acting, still they may not be able to drive themselves. So they should be accompanied by somebody, and they have to report to a company. Always you give them a telephone number to contact you if any problem. So these are all the things. And as I said, we need to recognize these areas, okay, landmarks, and we have reached the landmarks, then only we will be able to see all the pathology. So I leave you with this important slide. These are all the things this is a summary of the whole lecture. There are important 3 things in each oral cavity. There are 3 things to recognize. Cricopharynx, 3 things to recognize. Esophagus, 3 areas of narrowing. Stomach, how to reach the pylorus, 3 important steps. D1 to D2, the 3 important steps. J maneuver, most important, 3 important areas to see. So these are all the things you just remember. I'm sure there is a 2.5 days will be keep on repeating the same like a parrot. I'm sure by the time you can just do the same lecture like me. It's not difficult at all, and read the book when you have a time. Thank you very much.
Thank you, sir.
Any questions? Yeah.
After that we will authorize, so I will take 5-10 minutes.
Yeah.
After that we will start the procedure.
Yeah.
The patients are all.
Yeah.
Next presentation, Dr. Samiranjan Naik, Professor of General Surgery, GSL.
Nasal oxygen and pulse oximeter is a recommendation. Especially when you do, even though, especially when you give sedation, it is a must. Even otherwise, in ideal setup, pulse oximeter, nasal O2, because the tolerance of the endoscopic procedure is better with the nasal oxygen, pre-oxygenate, and pulse oximeter gives an thing. Even though nothing like clinical, you have to keep vigilant. You have to be always look at the patient. Very quiet patient also is to be very careful. Is he breathing or not? Okay, and sometimes we put the patient in an awkward place like ERCPs. Nowadays we have anesthetists present, that's good. Sometimes you put the patient on prone, and when they go for respiratory arrest, it becomes very difficult. Bring the patient supine, trying to resuscitate. You have to be always vigilance is the one thing that will not replace all the monitoring device, but pulse oximeter, ECG recording is usually ideal. In a patient with a known cardiac patient, put the leads also.
You have said any absolute contraindications, sir?
Yeah, there are. There is a topic we are going to discuss tomorrow, that's why I skipped. When to do, when not to do. That's an important chapter, we'll discuss that.
And routinely viral markers you do before endoscopy, sir? Viral markers.
There are on clinical background, because very difficult, because most of them will be referred by the GP. You can't expect. We don't do it routinely. You have to take a universal precaution. If they have HbA1c positive, what will you do? Same thing you do every time. You wear a glove, you wash your hands properly,
So
and
the thing is that routinely you do 3 or 4 scopies at a time.
yeah.
So if you don't do a viral marker for the patient,
No, there is
so
no.
next patient,
Yeah, that is not. If the patient is positive, then I will clean the scope better. That is not the answer. You just clean the scope as if everybody is HIV positive. That is the only way. We can't say.
so routinely what do you use to clean the scope, sir?
Yeah, we use. Chemical disinfection is universally accepted. Whether you do a manual or machine washing, it depends. 90% of the hospital they will do only manual washing, immersing the scope once you cleaned it. First cleaning is 90%. Disinfection is 10% of the job it does. And 20 minutes if it is a Sidex 2.4%. 10 minutes if you have parasitic acid, Parasafe. Parasafe is quite a good stuff in my personal opinion, because the Sidex obviously irritant to the eye and a very typical handle, but the Parasafe is reasonably safe and a shorter duration, 10 minutes. It brings down the immersion time to 10 minutes.
Between two scopes, you have to wait for 10 to 20
Of
minutes.
course, 10 minutes it will take. By the time you do all the paper or everything, 10 minutes will go, and that is worth waiting.
And one more thing, sir, you have set up for informed consent. I've seen a lot of literature on net, but in the Indian setup, what is the informed? Do you have any prescribed format for the informed consent?
Now you have to design your own info. As I said, it should have a written patient information leaflet. Okay, I have written in the book in English. You translate the whole thing in your own language, okay, and give it to the patient. Let the patient read. I've understood, I have read everything, I've understood everything, I'm agreeing for having. So that patient has to write in their own line, and with the witness, you have to ask them signature.
One more thing, sir, in the consent, what are the things we sometimes routinely miss in the scoping? So we ask for a repeat scopy also.
Yes, yes, of course.
That should be also mentioned in the informed, because sometimes patient may not be cooperative. Sometimes food might be there, sometimes we may miss.
Very well. Especially in a colonoscopy is very important. You may not be able to reach cecum. Sometimes you miss the lesion. Somebody find out medico-legally. So there are minimum three things they usually recommend. One, of course, I said perforation and bleeding. Second is a missing lesion is a probability. So you may ask to come for a follow-up, and always you come with a follow-up date has to be given. And if they have to strictly follow the instructions given.
Informed consent, you have tried missing lesions. There might be some missing.
Yeah.
Because regularly I do, and there are some problems with the medical gastroenterologist. So for that medical legal, what should be the informed consent?
No, this has to be included. Missing lesion is quite a probable thing. So if you have continue to have the symptoms, kindly come. We may have to do further investigation like that. You could need not be endoscopy itself. Further investigation, some other ways you need to identify, because very often persistent anemia, colonoscopy normal, we have fission, repeat colonoscopy found the lesion. Because we haven't gone. What we thought was cecum was not cecum. We stopped with the hepatic. These things are reality. So one has to cover yourself front and back. So you have to put nice words. So you need to have a legal experts to write the informed consent.
Sir, for that reason, most probably this is the topic we kept, that is called documentation.
I think I'll add one more thing. If you have a person with known viral positivity, schedule him as a last case, so that you will not be transferring him the fluids from one to the other, and you have the overnight sterilizing process for them. I think today all hospitals are insisting on that. So I think you will have if you have the time to go to the case sheet, you will know whether he is positive or not.
Background only you have to take, and the very important thing is, once you are very, very rigid in your disinfection protocol, these things need not be worried about. Only if you are already, doing half part, that's why
Next, we have to shift now. Patients are waiting. Find out from the hospital committee. Patients are ready, so we'll shift.
Not replaced by doing industry.
Most probably. Because I talked.
Small sandbag or a small pillow is important. Especially when you have broad shoulder. They should not have a twist like this. So it should be the head should be in left hand in the neutral position. Children may not be necessary because they have big head. Sometimes may not be necessary. And another important thing is this endoscopy available now can be used from children to 1 year onwards. There is no pediatric. Most of them will be doing pediatric. This 9 mm to be used for body removal. Whether you need a pediatric endoscope, no need. 1 year onwards, we have done most of the interventions with the same scope.
I think be safe and don't be sorry later.
Good morning, all the delegates and the participants, my respected colleagues. This is like only 5 to 7 minutes job for me. We had a mesmerized talk by our two guest speakers regarding the hardware of the endoscope and the steps of endoscope. We people are doing now also. We people everybody is having a smart system, smartphone, and we people are in the smart lab also. But everything nowadays has to be recorded, and has to be documented, because this discussion is going on. Suppose I will not reaching the SICM, better to document. Okay, I did not reach the SICM, better to document, better to document. So that's why this is a small talk that is called recording and documentations. So this is documentation. No job is complete without any paperwork. Even if now patients are demanding, give me a CD, give me a DVD, give me my video format, and everything should be documented. So this is one small like a paperwork is there. This is a research work, digital recording and documentation of endoscopy procedure. Do patients and doctors, they think alike? Just have a look. Most of the patient wanted endoscopy procedure, and they wanted sometimes the recording also. They want clear documentation. Sometimes they will ask, I will give some extra money, but I require that endoscopy video and documents. That is the practical now. But some of the doctors, because what we had a discussion, so I will have a fear. Most while I did not enter the SICM, why I should give the CD to him. So this is the paperwork. But nowadays, for the legal issue, better to document what we are doing. So this recording and documentation is basically required for our learning, for the research work, and as a teaching material also. So I will not give any, I will not go into details. Now everywhere is the digital imaging systems. See, now we are discussing, and everything is online with the Facebook. We are all are digitalized now. So it is now affordable, and documentation is widely available nowadays, and it is now a major role in the endoscopic reportings. So just we'll discuss when we will do the in the practice. The photo documentation is now a integral aspect of the endoscopic quality control, and set of images, because we can't give as for our wish. There is a set of images what our sir told, Dr. Ishwarman sir, regarding the some of the landmarks that snap has to be documented in the endoscopy reporting. So these are the documentation, crucial anatomic landmarks, already had discussion, and document the extent of examination. Again it is important, now we are discussing the extent of the examination. I entered up to the sigmoid colon, I saw splenic flexure, I saw transverse colon, that has to be documented, and it reflects the quality of the cleansing and the mucosal visualizations in the documentation. These are the things most probably IT people, they know much better than us. There are two teams are there, one is Olympus, another the Sonoscope. They are having a inbuilt now it is recording and documentation system. So these are the things we require. There is a digital capture device, there is a still capture that should be in the capture, and you have to store it, and there are some of the equipments they required for the recording purpose. So this is the quality of the image. We required a standard output. Previously we people are doing a ST, now we people are doing a ST camera system. Data how we are transferring, there is a compression also. Sometimes we are doing the video for 30 minutes, but when we will go to some of the presentations or when we will show some of the conference, we have to show within 2 minutes or the 3 minutes presentation. That I have to compress that video and I have to transfer and I have to show. And these are the image formats. These are the formats like a JPEG format, the BMP format, TGA format. These are the formats are available with our IT people. And this is the storage system. Now everybody is having a pen drive, they are having a USB system. There are a lot of storage systems nowadays, starting from the MB, GB, terabytes are there for the storage system, and this we can keep for like a central storage system. Even after 6 months patient will come, or after 1 year patient will come, we can show this is the video or this is the picture of the patient. Video editing, now most probably as for my knowledge, all we people, even sir and myself, we are well versed with the editing video, because when we are doing a laparoscopy surgery, we are editing the video so that we can show in the some of the conferences or now in the YouTube or in our personal profile. So video editing, we people should well versed, and we people should know how to edit the video. Again, I will not repeat, sir already explained regarding this is the standard picture has to be there in the endoscopy. It may not be there, proximal esophagus, distal esophagus, gel line with a diaphragm indentation, cardia and fundus retroflexed view, then body including the lesser curvature part, body retroflexed view, angle or insusura angularis, antrum, duodenal valve, second part of the duodenum. This is for the upper GI scope. These are the, we should be well versed. There is a snap system is there, we should capture these are the photos. Then we can select which are the printing. Suppose some of the printing images it can catch 4 images, better to give that 4 images which is important for the patient as a documentation. This is for the upper GI endoscopy. These are the landmarks we have to do. There is no excuse for this. We have to capture, these are the landmarks. This is for the colonoscopy. Same thing we are discussing, lower part of the rectum in the retroflex view, lower part of the rectum, middle part of the sigmoid colon, descending colon, transverse colon, ascending colon, cecum and ileocecal valve, cecum and appendicular orifices. This is nowadays almost like a guidelines or the mandatory for us. Suppose we did not went to cecum, better to document. We never saw the cecum. Sometimes you will see, we will saw the report, we will write ki patient is not cooperative. This is means we are safeguarding ourselves in the documentation, but better we should document it. So, video documentation of endoscopic procedures are becoming widely available. Now, most probably all our people who are doing endoscopy, they are, as per my knowledge, they are doing a recording system. And in certain situation, particularly when we do the therapeutic procedure, better to document in the video format. So, in therapeutic situation, video may be superior for the photo documentation. So, this is conclusion. I have to finish because all patients are waiting for live, accurate, and it should be adequate image documentation is an essential now part in our endoscopy or colonoscopy reporting. It should be very systematic, and systematic photo documentation is recommended by almost all the societies. Now also sir is telling that Efiages also they are telling it should be systematically, it should be documented, and this documentation in the upper and the lower GI scopy, and this should be incorporated nowadays in all our data system. So, this is regarding the small talk regarding the reporting and the documentation in the endoscope. Now we are having 6 stations, all the 6 stations we are recording, all the 6 stations we are documenting. So, these 6 stations, one is Olympus and the sonoscope, they are engineered, they will also inform how they are incorporated in their scope system now. They will also tell how they are recording and how they are reporting also. So, thank you very much. Sir, next what we should do, we will go for the, or we will go, or we will finish the sir's talk.
No, we will finish the live. Live is more. I told you, we will finish the live.
Because now it is 11 o'clock.
Yeah,
Yes.
we'll go live.
Group. Sir, is there already group list?
We grouped all the participants into 5 groups. There are total 6 stations, 2 colonoscopies and 4 endoscopy stations. There the faculty will be there, and they will be coordinating you. And a gentle reminder, please do your biometry 3 times a day, at morning 8 o'clock, afternoon 2 o'clock, and the time you leave the smart lab. Those the photos which have been taken.
Group 1 is endoscope, group 2 is endoscope, group 3 is endoscope, group 4 is endoscope. Group 5, there are 2 colonoscope is there. So, group 5, 9 people or 8 people. 9 people, 5 or 4. There are 2 stations for the colonoscope. Sir, is it okay? Or there are 4 endoscopy stations and 2 colonoscopy stations.
And please don't forget to have a photograph, because the photograph will be displayed on your certificate. So, kindly cooperate. Thank you.
Yes, sir.
That also you. Not the same station.
All the group, they have to rotate. Most probably group 1, Dr. Ishwarmurthy sir is staying. In the group 2, Krishnadas sir is staying. Group 3, we are dividing there, but everybody has to rotate. We are giving a buzzer system. After 20 or 30 minutes, they have to rotate.
30 minutes we will keep it that way.
Station 1 to the station 2 and station 3 they have to rotate.
There is a 5 minutes tea break followed by the live endoscopy. So you have your refreshments near the smart lab registration. Thank you.